Hello, I'm Phil Hopkins. I'm from the BJA, the British Journal of Anaesthesia, and I'd like to very much welcome you to this discussion of a key paper from the May 2021 edition of the BJA. And if I just share my screen with you, coming up very shortly will be the paper in question. And there you can see the paper, Avatar-Based Patient Monitoring in Critical Anaesthesia Events, a randomized high-fidelity simulation study. So to me, what struck me first of all was it's got a bit of a science fiction element to it in terms of the title. And I'm very pleased to welcome the lead author of that paper, David Tscholl, from the University Hospital Zurich, and also Dr. Craig Webster from the Department of Anaesthesiology in Auckland, who co-authored an editorial to accompany the Avatar paper. So firstly, David, could I ask you just to introduce yourself?
Yes, my name is David Tscholl. I'm an anesthesiologist here at the University Hospital in Zurich, Switzerland. I work 50% in clinic and 50% as in research. And I have been doing the visual patient or avatar-based monitoring studies for the last 8 years. And yeah, we have, with the British Journal of Anaesthesia, published our first study about the topic, and now also this simulation study. And we are very happy and glad to have found such great supporters for this project, because the success of the project also depended on your help, so to say, or on the publications helped us.
Absolutely. And Craig, welcome.
Thank you. I'm Craig Webster. I'm with the Department of Anaesthesiology at the University of Auckland and also the Centre of Medical Health Sciences Education. I'm a psychologist, and I've been doing human factors work in healthcare for quite a few years now, mostly in anaesthesia around organisation of workspaces and things like that.
Okay, so to the paper, David, what made you interested in this field of study? What do you perceive to be the clinical problem that you're addressing?
The main topic that this whole research is around is the concept of situation awareness. We wanted to address the problem of inadequate situation awareness, or the difficulty that care providers have in gaining and maintaining situation awareness. Situation awareness is a concept that originates from the aerospace industry, and it has 3 levels, essentially. The perception of the information elements in a system, their comprehension, and the projection of their meaning into the near future. So basically just knowing the situation, what is going on, and being able to make decisions with that information. And there has been a recent body of research that found that, like in aviation, in anesthesia too, about 3/4 of all critical incidents somewhere result in inadequate situation awareness, where, for example, some data was in principle there, but the care provider didn't see it, or they had a different mental model than what was really going on. So we specifically developed the visual patient tool to improve care providers' situation awareness.
Okay, thank you. Craig, is there a broader psychological context to this field?
Yeah, I mean, that's one of the things that interested me about this paper, was that there's a lot of sort of technological innovation that happens in anesthesia, but it gets introduced with very little sort of human factors work in terms of, is it a better improvement than the old model? You know, will it work in this context, and so on? So things like new monitors and different display formats get introduced into anesthesia all the time, and there's very little sort of testing before they get introduced. you sort of get a memo from hospital management saying there's a new monitor in use, and that's basically it. So it was interesting to see such a new kind of monitor displayed from David, but also the fact that he bothered testing it in a simulator first was very interesting to me.
Okay, so David, I mean, obviously the title is really attention grabbing. An avatar. So for old fogies like me, what is an avatar?
Yeah, it's actually a very old word. I looked it up on Wikipedia. It comes from Hinduism, and in Hinduism, it means ava means down, and tar means crossing over, and it was described to describe the incarnation of gods as humans on earth in Hinduism. So that's where it came from. A coming down like from the heavens and then crossing over into the world. And in computer science, it's a graphical representation of a user that can be an icon in an online forum or a 3D character in a video game, for example. And in our special case, it's the avatar of the patient or of the patient's situation, the patient's vital signs. We tried to bring that down, so to say, from the data streams into this picture.
Okay, and I hope you've got a little clip of the avatar so that everyone can see what we're talking about.
Yes, I do. I will try to share my screen. Just a second. Can you see this?
Yeah,
you see
it
that? Mm-hmm. Yeah. So this is, I unfortunately cannot show the latest version because the design patent is not yet filed, but this is the version we used in the study. So that's, it's good either way. This is our avatar. And in this situation, everything is safe. So things that we incorporated while we developed it from user feedback was for example, these white lines. These white lines always indicate the normal. And then the elements of the avatar indicate have a logical commonality to the reality that they mirror. You will understand in a second. For example, if the avatar becomes hypertensive, then the pulsation of the body goes out beyond the normal to indicate like a pulse pressure to a lot of pressure, right? Or if the saturation goes down, it will turn purple. We had to make it turn purple and not blue, because when we used the blue color, everyone thought it's cold. And I will bring it back to safe here, not to over crowd everything. But if you have a high end expiratory CO2 concentration, then the cloud, we call it the expiratory CO2 cloud, gets very, very large. And the brain activity, when the brain activity is high, then it opens its eyes or it closes them. And we have an indicator for an SD segment deviation in the ECG. Then the myocardium here appears hypoxic. And the neuromuscular relaxation, if it's relaxed, then it looks like this, and so on and so forth. Tidal volume, when the tidal volume is high, then the lungs get really high. And one thing that works really well is, for example, peripheral vision. You can't really read numbers with peripheral vision, but here, even if you look to the side of your screen, you will still see the color and the pulsation of the avatar. So that's we think a new quality that this can add peripheral vision monitoring, and somehow parallel transport of information, because if I look at the body here, then I will see at the same time its color and its pulsation speed, and I will be able to remember more vital signs than if I had to look and scan through the individual numbers. That's what we found in the early computer-based studies, that if you show this to care providers for 3 seconds, then the screen turns black. They will be able to recall twice as many vital signs than if they have to read the number, because in 3 seconds, you are only able to read 3 numbers, we found in an eye tracking study. And here you see more. Yeah. And also an important concept that we took out from this book, which I want to show because it's a very important book. It's by Mika Ensley. Mika Ensley is the world leading scientist in situation awareness research, and she made this book how interfaces should be designed specifically for situation awareness. And there she said that it's important to show information direct, and direct means to show what it means, and that's to find ways to show it so that people will know what it means without much cognitive load or having to think about.
Okay, David, thank you so much. It's brilliant. Let's leave it up there for a second. And Craig, do you want to come in there?
Yeah, I mean, I completely agree with what David's saying. I mean, this is one of the first examples I'm aware of that's moved away from the single sensor, single indicator paradigm that most anesthetic monitoring has been using up until now, which is the idea that you have a monitor on the patient and the monitor turns variables into a number which appears on a computer screen somewhere. And the computer screens, often there's 2 or 3 of them, and the single value for that sensor will pop up somewhere on the screen, but it's only one value, and it's not. And then there's a whole bunch of other values on the screens, and so the anaesthetist has to search for the value, integrate the value with all the other values on the screen, and work out what it means for the patient. Whereas this gives you a direct analog of what it means for the patient. You know, it combines it all together in a kind of sort of visual mnemonic, which is immediately and intuitively interpretable. Where
does audio information come into this? Is it a hindrance, or is it helpful? Is it additive?
No, I think it should become part of this. Of course, this opens a completely new possibility to introduce new audio for patient monitoring. And Philips, the licensor, or the ones who took the license for the visual patient, are working with an audio design firm. And they have just started working on sounds with the specific, to specifically make sounds for visual patient that could work with visual patient as well. But at the moment, we don't have sounds yet. So we have the normal sounds that you have in the monitor, and this is just a visual, an additional visual indication. But it's a platform, and I think there's ample opportunity to come up with cool new sounds that fit this kind of visualization.
But in general terms, Craig, are visual and audio signals always complementary, or can one obscure the other?
They're not always complementary, but I mean, if you're going to make an integrated display like this, you would try to design them to be complementary. I mean, part of the problem with alarms in the operating theatre is there's just too many of them, and people lose track of what's alarming because a lot of them sound the same, and we all know the problems of alarm overload and alarm fatigue. There's been some studies that show an alarm goes off in the ICU every 4 minutes, 24 hours a day. That's just too many.
Mm-hmm.
So making something like this, which integrates the alarms into a more easily interpretable image, means that it's less cognitively demanding to interpret it. But also, if you're able to integrate the sound alarms into this as well, hopefully you can manage them to some degree and reduce the number.
Okay, great. So, David, if I could ask you to stop the screen sharing just now. And obviously, if you want to bring that back on or show anything else to help illustrate our discussion, please feel free to do so. But I'd like to move onto the setting for the study, because obviously, with anything new, as Craig mentioned at the beginning, we would like it to be evaluated and compared to what we know and what we're used to. So the setting for the study was high fidelity simulation. Why did you choose that, and what's the advantages and disadvantages from going straight into the OR and having a real life evaluation of the avatar?
Our main consideration was that we always from the start had this incremental approach in mind, to do a lot of laboratory computer-based studies, then do a simulation study, and then do a big data real life study. So the product last year, when we did the simulator study, the product was nowhere near ready to be to come into a real OR. So the best we could do at this time was a simulator study, but we didn't only do it because we couldn't do the other. We also did it because in a simulator study, you have the opportunity to test, for example, critical scenarios that you could not really test in real life because they happen too infrequently. And we wanted to make the simulation study as good as possible. And in our research, we found that to make the best possible simulator study, we have to do a high fidelity simulation study, because that we hoped would also increase the validity of the results that we find. If it's more realistic, it's better than if it's less realistic. And so we used a patient simulator that could study, that could produce its own vital signs, that had breath sounds, that had heart sounds, that had a realistic feel. And in addition to that, we also went into an environment that was realistic. We went into a spare OR at our hospital in a normal, regular operating room area, and did all the simulations there with the people who were there. And they used all the same equipment, the same monitors, defibrillators, ventilators, airway devices. And yeah, that's the main advantage I see. And the disadvantage is probably that no matter how realistic a simulation will be, people will still somewhere in the back of their heads know that it's a simulation. So you can't one-on-one bring it over into the real life. But I think it was a very important stepping stone for us, also with the study design that we choose, the non-inferiority approach, where we wanted to find or generate evidence, look for evidence that the tool was safe or was not somehow lowering the performance. That was very important for us.
Okay, so you thought that was essential to demonstrate that it wasn't worse before you moved into a real life situation.
Correct. Now we have found that, and we can, with a little bit less or a little relaxed, can we go into the real study.
Okay, because so that brilliantly leads us on to what your main findings were.
Yeah, to explain that, should I give just really quickly explain what we did first?
Well, I think if you can do that whilst telling us what you did and what you found. Yeah.
So we had 52 teams consisting of 2 persons conducting 154 simulations. Each team did 3 critical scenarios. They were malignant hyperthermia, bronchospasm, and myocardial infarction. And they did it randomly with 3 monitors, only the avatar, only conventional, and a split screen 50-50 avatar, and the other 50% conventional. And we recorded these scenarios and then did a video-based analysis where raters analyzed the videos and graded when they performed a critical item, for example, because that was the primary outcome, the time to performance of critical tasks in the scenarios. There we took the Stanford emergency manuals for the situation. There is a Stanford emergency manual for myocardial infarction, for example, and it has critical items. And these are the items that we use to grade the performance. And then the main results we found was non-inferiority for split screen. That was what we were hoping for with this study. So the split screen, there was no difference between split screen or only conventional. It was non-inferior. It's the same. And the most striking result was that we found superiority of the avatar-only display regarding communication of the correct cause of the emergency in the simulations. So somehow the participants, when using avatar, set the correct diagnosis more frequently and earlier. And this was well statistically significant in avatar only, and it just barely the lower half of the lower part of the 95 confidence interval just barely went left of 1 and it rests at 0.97. So there is it's probably, the effect is probably the same also in split screen, but just not
I guess we're always, whenever we do a study, the results aren't entirely as we would have hoped, or they're rarely as good as we would have hoped. What do you think may have been the reasons for? You've demonstrated it's non-inferior, you've demonstrated there's some definite benefits of it in some elements of the outcomes you were looking at. Why do you think you perhaps didn't get a clear marker of superiority across the board with your outcome variables?
I think that in a simulator study, a lot of things influence the performance of the teams. If we, like in our computer studies first, where you really just show the avatar to people and then ask them, what have you seen? That's a different kind of situation than a complex simulation where a lot of things influence the performance. So we already, before we started the study, we already knew or thought that the effects would not be as large as they were when the only thing we studied was the monitor. And I think maybe it's like always with technology or nowadays, like technology, the additional benefits of new technology are relatively small, and they may be in specific for specific situations or in specific aspects. And another thing is the people working with our avatar had very, very little introduction. They watched a 6-minute introductory video and then could ask their questions, and then they were sent out into the simulations and had to work with it. It's going to be very interesting to see when the product is released and people really have time to train, if that will affect or change the perception regarding the tool.
Mm-hmm. So as a neutral, Craig, do you think that's credible? That do you agree with that?
Yeah, I think there was some evidence of a learning effect in your data, David. So people had much more experience with the conventional system, so they're much more familiar with it. And then the new avatar system, they had much less experience with it. So, they haven't been trained on it as such. So I think the fact that you found, sort of a neutral effect or a non-inferior effect in that condition actually is a pretty positive thing. And there is some evidence in your paper that actually, despite that, it performed better. So.
And
that's really encouraging, isn't it, David?
Yeah, it's cool. But the longer I work with this project, the more I also think, or I hear from my colleagues, that it's just a different way of doing monitoring. It's kind of, some people have compared it like the speedometer in the car. Some have a digital speedometer, and side by side with a round dial speedometer, they can both be there at the same time, and they both have their benefits, because that's also important. We don't intend to replace the numbers with the avatar. We see this as a supplement to a situation awareness supplement. The avatar gives you the situation awareness, the number gives you the precision, because the avatar is not as precise as the numbers are.
Craig, is that, would you expect the system to be more helpful to some people than to others? I mean, we get the concept of people, as David has alluded to, who are very digital, like to see the numbers, and others say that they like a global overview. Do people's brains work differently to each other?
I think to some degree that might be true, but I think to a much larger degree, we all know that human beings have 2 arms and 2 legs, and different parts of our body behave differently in different circumstances, depending on what condition we're in. So the fact that you put all those numbers together into an avatar, which overestimates those changes and body processes, means that you've got all that information now in a much more digestible form for the brain, because the brain largely is a pattern matcher. You're looking for subtle differences and patterns, and that's what expertise largely is. Actually, it's just a very sophisticated form of pattern matching. So this display is much more psychologically well informed than a whole bunch of digital displays on a screen, because it's much easier to absorb the information this way.
Okay, now if we're looking ahead, David, you've already mentioned that the avatar that you've used for this study has been improved upon. What other steps are you planning in the development of this project?
Now we are currently planning a big data study that we want to do for the real-life introduction. The real-life introduction in a limited release form is scheduled for later this year. And then we will record all monitoring data in a high frequency, once per second, and see if the introduction of this product changed anything in the vital sign courses of the patients, because we think if they see it earlier, they may be able to correct things earlier. And then in parallel, we are working on making a 3-dimensional version of Visual Patient, because that's the logical next step, probably. Everything is 3-dimensional. Now it's still 2-dimensional, which is not bad either, because the children's books, at first, they are 2-dimensional as well. And it's a good format to transport information easy. 3D can bring in more complexity. And one very exciting study we are doing with the Institute of Machine Learning of the Swiss Federal Institute of Technology is making predictive models specifically for visual patient. They are a bit shorter than typical predictive models, but they can be integrated seamlessly into the visual patient interface. For example, if we know if a model gives us balanced accuracy for the prediction that in 1 minute will the temperature reach its lower limit, then visual patient can show snowflakes or ice crystals once every couple seconds. And the closer a prediction gets, or the more sure that the prediction will actually happen, the more prominent can we integrate the next state that the prediction is predicting into the current visualization. So what are great advantages here? We don't need any more numbers for these predictions, because if you like added on a conventional monitor 2 numbers for each vital sign, upper and lower prediction, then nobody could read the monitor anymore. So,
yeah, so you're in essence, you're taking trends and using the algorithm, extrapolating as to what's going to happen based on lots and lots of data.
Correct. We did the study. The models are now finished. We are just externally validating them now. And for this data, we used 36,000 anesthesia cases from the University Hospital Zurich with 1 minute sample rate. And last year, we recorded 2 times 600 with 1 second sample rate to refine the models, because for temperature and for ST segment, 1 minute works very well, but for pulse rate or blood pressure, 1 second works much better, because they are more dynamic. So that's the most exciting, the scientifically most exciting part.
Okay, well now we can have a real bit of fun and get out our crystal balls. I mean, Craig, where can you see this field going to in the future?
I mean, I think what David was mentioning about the deep learning algorithms for prediction is very interesting, because you know, lots of people are talking about AI in healthcare and that kind of thing, but AI has a lot of limitations, and one of them is that the AI never actually understands what it's doing. It doesn't attach meaning to the data it processes. Sure, it can say, it can put a snowflake on a screen if it knows that there's a chance the patient's going to be getting cold. But it takes a human being to actually understand what that means and alter care for the patient. So the attribution of meaning is an important thing that the human brain can do that AIs can't do. And no one really knows how to make AIs understand the information they process. That's still an unsolved problem in artificial intelligence. So for a long time, into the foreseeable future, humans will be the meaning makers, and AIs might be something which helps us make meaning, but they won't be replacing healthcare practitioners. And that's kind of leading us towards a future of augmented cognition, where we have these sophisticated devices and systems which basically sort of increase our cognitive capacity to process information.
And David, anything you'd like to add in terms of what you might be dreaming of developing?
Yeah, I have to be a little careful with what I dream, because I have been lucky in the past to, I, for example, dreamed that this paper would go into the BJA, and here we are. I agree with Craig. I absolutely also believe that for a long time, humans must be will be the decision makers. And there will be a long time that I can sit in my car here and drive autonomically to another country before I will be replaced at my hospital and have the computer do anesthesia. And that's where visual patient is fits in well, because visual patient is made for the user, is made to augment help the users make their decisions, and not some far out artificial intelligence thing that is not so can't be introduced this fast because of all kinds of regulatory things and liability reasons. Although I also have to say that, especially in aviation, auto-land features are now available for small aircraft. That is something that no one thought would be available 5 years ago. And so the technology makers are making some progress also with this artificial intelligence, but the artificial intelligence itself is not yet there, because if it were, it could probably make this interview for us already with our avatars, because it could read our papers and then make the greatest interview ever.
Yeah, well, I can assure everyone that I am not an avatar. But I've really enjoyed our discussion this morning. David, many congratulations on your study and on your paper. And I think all of those involved, including the 52 teams of anesthesiologists, deserve a lot of credit. They've really put in a lot of hard work, as have all the authors in the study. And Craig, I really enjoyed reading the editorial, and I would thoroughly recommend anybody who's interested to read the editorial. It really does complement the paper superbly. So both of those are appearing in the forthcoming issue of the British Journal of Anaesthesia. And just to mention that all the authors' declarations of interest are obviously detailed in the papers themselves. So once again, thank you, David. Thank you, Craig. And it's goodbye from all of us.
Goodbye.
Thanks, Philip. Thanks, David. Bye-bye.